Hello, this is Robert Boutan, and we're going to be talking about bone tumors and tumor-like lesions with a systematic approach. Our objectives are quite straightforward. We're going to talk about diagnosis of bone tumors and tumor-like lesions, looking at certain findings or discriminators to help us narrow the differential diagnosis. We'll then talk very briefly about staging and then focus on classification of bone tumors into 6 basic categories. Of course, this is only an introduction. We'll be focusing on generalizations rather than the exceptions to the rule. Now, when it comes to diagnosis, it turns out that certain discriminators or findings can be helpful for us to go through a checklist. We start with patient age and lesion location as being 2 of the most important factors. We analyze the pattern of bone destruction. We look for a tumor matrix, and then we analyze the tumor extent. So first, let's start with patient age. Just like with love, with bone tumors, timing is everything. When patients are less than 20 years of age, there are a number of benign lesions that can occur. The most common kind of bone tumor or tumor-like lesion that we'll see in this age group is a fibrous cortical defect or non-ossifying fibroma. Here we see an example of a non-ossifying fibroma measuring greater than 3 cm in size. We'll talk more about all of these entities in detail, but first I just want to run through the different lesions that can occur less than 20 years of age. Besides fibrous cortical defect or non-ossifying fibroma, another classic is the solitary bone cyst, here shown with a pathologic fracture. Also in this age group, the aneurysmal bone cyst, an expansile or aneurysmal bubbly-looking lesion like we see here. We'll also be talking later in detail about osteoid osteomas and osteoblastomas that occur in this age group. Here's an example of an osteoid osteoma. Note the nidus is less than 1.5 cm. Also in this age group, another one of the classic benign lesions is fibrous dysplasia. Also in this age group, there are a couple of malignant bone tumors that come up again and again. The 2 classic important ones that everybody needs to know about include Ewingsarcoma and Osteosarcoma. And so we'll be talking more about those later too. Over the age of 30, some of the other lesions that need to be considered include chondrosarcoma, shown here both on CT with the chondroid matrix and on MR with the way chondroid matrix looks on a T2 weighted image with that lobulated T2 hyperintensity. Over the age of 40, the most common lesions by far are going to be metastases and myeloma. So we've talked about patient age. Let's talk about lesion location. After all, like in real estate, it's location, location, location. When it comes to long bones, the classic aggressive lesion that we see in a skeletally immature patient is a Ewingsarcoma with an aggressive pattern of periosteoreaction, ill-defined osteolysis, and an adjacent soft tissue mass, Ewingsarcoma. In the metaphysis, there are a number of lesions that can occur in this rapidly growing portion of bone in young individuals, including a non-ossifying fibroma, here with a pathologic fracture. Osteochondromas and various sarcomas also can occur in the metaphysis of long bones. In the epiphysis, the differential diagnosis gets shorter. But one thing that you should keep in mind is that when we think about epiphyseal bone tumors, we also have to think about epiphyseal equivalents, such as the patella. So here is an example of a chondroblastoma in an epiphyseal equivalent, the patella. Here, another type of bone tumor that characteristically occurs in the metaphysis and adjacent epiphysis, here a giant cell tumor of bone, but also a giant cell tumor of bone affecting an epiphyseal equivalent. So patient age, lesion location. What about the pattern of bone destruction? Well, this is important because it reflects the biologic activity or growth rate of a lesion. So we talk about a lesion looking aggressive if it has a permeative or moth-eaten pattern of bone destruction, with a zone of transition that is wide and a lesion margin that is non-sclerotic, as in this case of a patient with lymphoma. On the other end of the spectrum, we talk about a lesion being non-aggressive if it has a geographic appearance with a well-defined border, with a zone of transition that is narrow, and a lesion margin that is sclerotic, as we see in this case of a patient with a solitary bone cyst. So, patient age, lesion location, pattern of bone destruction. What about tumor matrix? Well, that's important because it helps us classify a tumor by tissue type. And of course, we talk about an osteoid matrix when we see mineralization that looks ivory, fluffy, or cloud-like, like we see here in this osteosarcoma. Or a chondroid matrix when we see mineralization that has the appearance of arcs and rings, punctate or stippled mineralization, as in this chondroid lesion that ended up being a chondrosarcoma. And what matrix is this? Well, here's where we talk about a ground glass matrix, and by that we mean this sort of hazy opacity that is commonly associated with fibrous dysplasia. So, we have our checklist of discriminators: patient age, lesion location, pattern of bone destruction, tumor matrix, and then tumor extent. And by that, we not only mean within the bone and adjacent soft tissue, if it's involved, but also within the skeleton as a whole. Is it affecting just one bone, that is monostotic, or is it affecting multiple bones, that is polyostotic? Because polyostotic lesions have a limited differential diagnosis. Some people have a crazy mnemonic, FEMI, as their differential diagnosis of multiple lytic lesions in the skeleton. And that's their way of remembering F for fibrous dysplasia, E for eosinophilic granuloma or Langerhans cell histiocytosis, E for multiple enchondromas, M for multiple metastases or myeloma, H for hyperparathyroidism that may cause multiple brown tumors, and then very importantly, infection. It turns out that infection sometimes can be mistaken for a tumor and vice versa. And so when looking at a focal lesion in bone, keep in mind that it's not always going to be a neoplasm. Infection should be in the differential diagnosis if appropriate. So after we've gone through our checklist, we try to commit in our report to one of 5 report conclusions. Do we think it's benign? That is a don't touch lesion like this non-ossifying fibroma, a geographic lesion with well-defined margins, a sclerotic rim. Or do we think that it's almost certainly benign? In this category, we might think about doing follow-up radiographs, such as for a case of presumed fibrous dysplasia, or in this case, heterotopic ossification. A third category of report conclusion is that we're dealing with a benign symptomatic lesion. Surgery may be indicated, for example, with curettage and packing of the lesion in patients who have a giant cell tumor of bone, a chondroblastoma, or, as was done here, for a solitary bone cyst. That stippled mineralization within the lesion is not chondroid matrix, but rather the packing material. In some cases, we have to conclude that the findings are equivocal. We don't know whether it's benign or malignant. We try to keep this group small because these patients, most appropriately, will go on to biopsy, as in this case of a patient with myeloma. And finally, the report conclusion may indicate that we're dealing with a presumably malignant lesion, such as this osteosarcoma, with an aggressive sunburst pattern of periosteal reaction. Osteosarcoma. Moving on to staging, there are 3 variables that are looked at classically, namely the histologic grade, whether it looks low or high grade under a microscope. In addition to histologic grade, local tumor extent is evaluated. Is the lesion intracompartmental, that is, contained within the compartment of origin, or has it extended beyond the compartment of origin, extracompartmental? And finally, beyond histologic grade, and local tumor extent, we look for the presence of metastases, which defines stage 3 disease. And if you forget all that, the important concepts are merely that the goal of staging is to stratify patients into groups for prognosis and treatment. It's a multidisciplinary effort of radiologists, surgeons, and others. Biopsy should ideally be performed for primary bone lesions at the institution doing the definitive treatment. So now, in our time remaining, let's talk about the classification of tumors into different tissue types according to what they most resemble under a microscope, whether they look like bone, cartilage, fibrous tissue, vascular tissue, marrow elements, or certain miscellaneous tumors. So first off, let's talk about the osteoblastic lesions. There's some benign ones like the anostosis or bone island, osteoid osteoma, and osteoblastoma. In the malignant category of osteoblastic lesions, of course, there's osteosarcoma. So first, a few words about the anostosis or bone island. It's simply a sclerotic lesion in cancellous bone, often with spiculated margins, that needs to be differentiated from a blastic lesion caused by a primary metastatic process. Here, you see the characteristic appearance not only on radiography, but also on the corresponding MRI. Simply a bone island or anostosis. The differential diagnosis may include a blastic metastasis, most commonly from a primary prostate, breast, or GU primary. And the workup may include a bone scan, which is essentially negative in the vast majority of cases. What do we have here? Multiple sclerotic foci in a patient with osteopoikilosis, where the bone islands are multiple. And this, again, is clinically insignificant, except that we need to differentiate it from bone metastases, osteopoikilosis. How about the diagnosis here? Well, this is a case of an osteoid osteoma. Note that the nidus, by definition, measures less than 1.5 cm, may or may not have an area of central calcification, and is commonly surrounded by dense reactive bone. These may be treated by CT-guided ablation, as was done here effectively. The classic history is that the central nidus has adjacent reactive bone, both on radiography and on CT, like we see here, with aching pain, worse at night, relieved by aspirin. So if you get a case like this, where you see sclerosis adjacent to the SI joint, what would be the appropriate workup if you're worried about an osteoid osteoma? Well, osteoid osteomas, it turns out, are best shown by CT because they very confidently will show a small nidus and the adjacent reactive sclerosis, as in this case. What's your diagnosis here? 2 axial images, a companion case to the last one, showing a small nidus of an osteoid osteoma and adjacent reactive bone edema. So on MRI, the nidus is commonly seen, but is subtle, and there's a lot of surrounding edema. Osteoid osteoma, the differential usually includes or may include a Brody's abscess. Moving on to osteoblastomas, by definition, the nidus is greater than 1.5 cm, and the histology is similar or identical to that of osteoid osteoma. With osteoblastomas, unlike osteoid osteomas, the targets are usually the spine posterior elements or flat bones, here the ribs. With osteoblastomas, the lesions are commonly expansile, and they may look lytic and or sclerotic. So in this case, the lesion is expansile and sclerotic. Here's another osteoblastoma that is expansile and sclerotic, this time in the spine posterior elements, with a characteristic rotoscoliosis that often accompanies the finding of osteoblastoma. So when we see a lesion in the posterior elements, whether it's sclerotic or in this case lytic, we may want to think about osteoblastoma. In fact, lytic lesions in the posterior elements can be caused not only by osteoblastomas, but by some other types of lesions as well. Some people like using the GO-APE differential diagnosis for lytic lesions in posterior elements. That differential diagnosis of GO-APE includes G for giant cell tumor of bone, O for osteoblastoma that we've been talking about, A for aneurysmal bone cyst, shown here with multiple fluid levels, P for plasmacytoma, and E for eosinophilic granuloma or Langerhans cell histiocytosis. GO-APE, the differential diagnosis of a lytic lesion in the posterior elements. Moving on to this case, what do you think? What's the best diagnosis? Would you say acute or chronic osteomyelitis, C, osteosarcoma, D, synovial sarcoma, or E, Paget's disease? Well, the correct diagnosis here is osteosarcoma. Note the sclerotic osteoid matrix with an aggressive periosteal reaction and an ill-defined zone of transition. So let's talk about malignant osteoblastic lesions, osteosarcoma. After all, it is the second most common primary malignant bone tumor. Osteosarcomas most commonly are of the conventional subtype, affecting the metaphyses with a permeative pattern of bone destruction, aggressive periostitis, and an adjacent soft tissue mass. And if you see these findings, what might be the next diagnostic test of choice? In most cases, the next diagnostic imaging test of choice is going to be an MR exam to look for local tumor extent and any skip lesions. When you do get the cross-sectional imaging, what is it that they, the clinician, the surgeon, will want to know? Well, they will want to know about local staging, including whether there is any involvement of adjacent neurovascular or articular structures. In this case, you can see that there's a nice fat plane between the lesion and the adjacent popliteal neurovascular bundles. So there was no encasement in this case. What else do we look for? We look for any skip lesions. Look at the proximal femur here. It looks clean. No skip lesions in this patient with an osteosarcoma in the distal femur. With osteosarcoma, metastases tend to go to the lung or bone. And in fact, skip lesions within bone have been reported in up to about 10% of all cases. With osteosarcoma, there are some other subtypes, however. Much less common than the conventional type is the telangiectatic subtype, a particularly aggressive type of bone tumor characterized by osteolysis and often minimal or absent osteoid on radiographic exams. One of the characteristics of telangiectatic osteosarcoma on cross-sectional imaging is that it's hemorrhagic and has multiple fluid levels. There are some even less common types of osteosarcoma. The parosteal type of osteosarcoma is a relatively low-grade type of osteosarcoma with a relatively good prognosis. And we look for an area of exophytic, often densely mineralized exophytic mass off the bone. Here, another example of a parosteal osteosarcoma. It's exophytic and densely mineralized. Even less common than the parosteal osteosarcoma is the periosteal osteosarcoma, classically seen as an extrinsic lesion with saucer-like cortical erosion and may not have abundant visible radiographic mineralization. And finally, there is a secondary type of osteosarcoma, typically occurring in older adults after the age of 60 with certain risk factors, namely Paget's disease and a history of radiation therapy. Here in the scapula, you can see this area of dense mineralization with some adjacent osteolysis. On CT, these findings are confirmed, and this was a secondary osteosarcoma after a history of radiation for breast cancer. Let's move on to chondroid lesions. And here, again, we can talk about benign lesions, benign enchondromas, chondroblastomas and osteochondromas are what we're going to talk about, and also malignant lesions, namely chondrosarcoma. With the benign enchondromas, we look for a geographic lesion with a narrow zone of transition and, of course, a chondroid matrix, like we see here. The one exception about seeing a chondroid matrix is in the hand. Enchondromas are common in the hand, like in the phalanges here, and in the hand they may or may not have a visible chondroid matrix. As with other lytic lesions, we should always look for complications such as fracture. So both of these enchondromas have been complicated by fractures. Besides pathologic fractures, another complication to look for with enchondromas is dedifferentiation into a chondrosarcoma. This one's not a diagnostic dilemma. You can see the huge, bulky, soft tissue mass adjacent to the lesion in the bone. And what about this case? What's your best diagnosis here? Ollier's disease, McCune-Albright, fibromatosis, macrodystrophia lipomatosis, or Kumrati-Engelmann. Well, the answer here is Ollier's disease. Note the presence of these rather bizarre-looking osteolytic lesions that represent multiple enchondromas. Now, multiple enchondromas are present with both Ollier's and Maffucci's disease. We see them as chondroid lytic regions with a columnar configuration. In both cases, there is some increased risk of sarcomatous transformation. With Ollier's disease, shown here, you can see just how bizarre and deforming these columnar areas of osteolysis are. In Maffucci syndrome, there are also multiple enchondromas, but in addition, we look for the presence of soft tissue hemangiomas that we can identify radiographically by the presence of phlebolyths. With Maffucci syndrome, there's a particularly high rate of sarcomatous transformation, often quoted as 20% or more. Moving on to chondroblastoma. Chondroblastomas are classically geographic lytic lesions that occur in the epiphysis of young patients. So when you see a lytic lesion in the epiphysis of a kid or young adult, think about chondroblastoma. Chondroblastomas on CT will have a characteristic chondroid matrix in most cases, and this is easiest to see on CT. Moving on to osteochondroma. Osteochondromas are typically metaphyseal lesions. Note that the cortex and the marrow are in continuity with the underlying host bone. The cartilage cap should be less than 2 cm in adults for a benign osteochondroma. Osteochondromas may be described as having a sessile or broad-based appearance, or having a pedunculated appearance in which the stalk points away from the nearest joint. Multiple hereditary osteochondromas can result in this sort of appearance of bilateral metaphyseal or metadiaphyseal widening and deformity. Most commonly, we see it in the knees, in the shoulders, and in the hips. Complications may be associated with the deformities that occur with multiple hereditary osteochondromas. What complication occurred with this osteochondroma? Well, fractures may occasionally occur through these osseous excrescences. And what about this complication in a patient with an osteochondroma? This patient had neurovascular impingement, so we need to be on the lookout for these osseous excrescences pushing on adjacent nerves or vessels. There are other complications that can occur when there's an osseous excrescence. In this case, the femur and the ischium were abutting one another because of the osseous excrescence off the femur, resulting in ischiofemoral impingement. So, we want to make sure in an adult that the cartilage cap is less than 2 cm in thickness. If it's more than that, then we might need to worry about the presence of dedifferentiation into a chondrosarcoma. Next, we're going to talk about chondrosarcomas, the third most common primary malignant bone tumor. How do we differentiate chondrosarcomas from enchondroma? Well, one of the most important features is a clinical one. Simply, the presence of pain is associated with chondrosarcomas. Lesion size is also an important feature. When the lesion is greater than 4 cm in the axial skeleton or in a flat bone, we're going to be worried about a chondrosarcoma. Here, the axial CT shows a bulky soft tissue mass with chondroid mineralization. There are some other features, aggressive features, that are associated with chondrosarcoma, namely the presence of cortical destruction that is more than 2/3 of the thickness of the cortex. In addition, the presence of a soft tissue mass, like we see here, is characteristic of chondrosarcoma and helps us differentiate it from an enchondroma. Next, let's talk about the topic of fibrous lesions, both benign, fibrous dysplasia and non-ossifying fibromas, as well as malignant fibrosarcoma. With fibrous dysplasia, we typically consider it as a developmental lesion, most commonly seen in patients under the age of 30. It may appear as sclerotic and or lucent, but does not have any periostitis, unless there's a fracture. With fibrous dysplasia, there's classically a ground glass appearance, a hazy opacity in a lytic lesion. Fibrous dysplasia may be described as resulting in a deformity, a shepherd's crook deformity, and that's simply the varus deformity that occurs in the proximal femur in this condition. With fibrous dysplasia, it also can be described as often looking like a long lesion in a long bone. Fibrous dysplasia may be monostotic or polyostotic, and when polyostotic, we talk about the triad of McCune-Albright, namely polyostotic fibrous dysplasia that's associated with café au lait spots and precocious puberty. Fibrous dysplasia on bone scan often results in intense tracer accumulation, here in a case of polyostotic fibrous dysplasia. Moving on to non-ossifying fibromas and fibrous cortical defects, they're the most common bone tumor or tumor-like lesion, most commonly seen below the age of 30. Non-ossifying fibromas are diagnosed when the lesion is greater than 2 to 3 cm, fibrous cortical defects when less than 2 to 3 cm. They're identical histologically. They both have a preference for affecting the metaphyses in an eccentric location with sclerotic margins, and these are the quintessential don't touch lesion. They should not be biopsied. Moving on to vascular tumors, let's talk briefly about benign and malignant vascular lesions. Of course, we commonly encounter hemangiomas in the spine, commonly defined as benign proliferation of vascular channels. Both on radiography and on CT, we look for the presence of coarse tuberculations. These coarse tuberculations on CT are interspersed by the presence of fat, and the fatty overgrowth between those tuberculi results in high T1 signal intensity on MRI. And what's the diagnosis here? Radiograph, FATSAT T2, and a post-GAD image. These are findings of an aneurysmal bone cyst. What do we look for with an aneurysmal bone cyst, and why does it occur? Well, aneurysmal bone cyst may be considered primary, associated with trauma, or secondary, in which case they're associated with other tumors of bone, giant cell tumor of bone, chondroblastoma, and osteoblastoma. Aneurysmal bone cysts are expansile or aneurysmal and have a rim of intact cortex or periosteum classically, with a well-defined margin. On MR, we commonly see fluid levels with only peripheral marginal enhancement. There is a differential diagnosis for fluid levels, including telangiectatic osteosarcoma, ABC, and the primary bone lesions associated with ABC. Finally, a few words about marrow tumors. malignant melanoma is the most common primary skeletal malignancy in which malignant plasma cells replace normal marrow. Multiple myeloma occurs typically after the age of 40 and targets red marrow, so not the distal skeleton. And of course, we look for multiple small punched out lytic lesions, here shown in the skull, as well as in the humerus. Multiple myeloma. Plasmacytoma is myeloma at a single site, and patients typically develop multiple myeloma within 5 years. It is often seen as an area of osteolysis that's expansile, but no visible matrix, here with a pathologic fracture. A couple of miscellaneous lesions to talk about in our final minutes, starting with solitary bone cyst, also referred to as a unicameral bone cyst. It's a true cyst, most commonly seen in kids, as an osteolytic lesion with a narrow zone of transition, often somewhat expansile, and often presenting when there's a pathologic fracture with a fallen fragment. Targeting the metadiaphysis centrally, there usually is not periostitis unless there's a fracture, in which case we do look for the fallen fragment sign. Here, 3 cases of solitary bone cysts with pathologic fractures. Finally, let's talk about giant cell tumor of bone, typically occurring in skeletally mature patients as an eccentric lytic lesion in a subarticular location with a non-sclerotic margin and narrow zone of transition, giant cell tumor. Most commonly, these occur adjacent to the knee, like we see here, or adjacent to the wrist, here in the distal radius, giant cell tumor of bone. Ewingsarcoma is the second most common primary malignant bone tumor in kids. It's one of those small round blue cell tumors that is included along with Langerhans cell histiocytosis and osteomyelitis as having a similar appearance. Ewingsarcoma is an aggressive lesion. When affecting long bones, it's usually targeting the diaphysis with an age peak of 10 to 15 years. What about this 24-year-old male? There's a big soft tissue mass. It's affecting a flat bone. There's no osteoid matrix. When we see a lesion such as this affecting flat bones in a young individual with a bulky soft tissue mass and avid FDG accumulation, think Ewingsarcoma. Here, in a 74-year-old male on the other end of the age spectrum, we see a very ill-defined, aggressive-appearing lesion, not from a Ewingsarcoma, but from a lymphoma, which may also affect flat bones with no osteoid, but in a completely different age group. And finally, metastases. They're at least 25 times more common than primary malignant bone tumors. Often they're polyostotic when they are diagnosed, and they target usually the more central skeleton, proximal to the elbows and knees, sparing the distal skeleton. When we see a lytic metastasis, we think about lung, kidney, and breast primaries, such as this pathologic fracture at the lesser trochanter from a renal metastasis. And when we see a blastic metastasis, we think about prostate, breast, or bladder primaries, such as this ivory vertebral body. So with that, I think we've achieved our objectives, talking about diagnosis, staging, and classification of bone tumors. Thank you.